My name is Callum and I am an orthopaedic foot and ankle surgeon, and my main practice is in Windsor, just west of here, but I've been coming to the Fortis Clinic for about a year now. And I'm going to talk about this, about the ankle. Probably the nearest thing to tennis ankle is the inversion injury. And really, if you look at the types of injuries that you would get in tennis, or the types of injuries I would see, they'd probably be divided into acute and chronic. And certainly, by far and away, the most common acute injury is an inversion. And you'll all recognise that. And obviously, it's the most common injury in the musculoskeletal system, full stop. Counts for probably 20 to 25% of all MSK injuries. We do also see in the non-elite population, in fact, the non-competitive population really, ruptured Achilles tendons. And this is quite common in sports which call upon sudden explosive actions such as tennis or squash or badminton. And in the chronic ones, well, there are chronic ankle problems, possibly as a result of recurrent inversion sprains, and then Achilles tendon problems, which of course you'll also see very frequently too. And I think in the professional, or certainly the competitive versus the non-competitive would probably be better than professional versus amateur, you tend to see more acute injuries in competitive players, and certainly fewer ruptured Achilles tendons. So this is an interesting paper, relatively recent. Data from 15 years of the US Open tennis, looking at the injuries encountered. And what you find is that lower limb injuries outnumber upper limb, certainly in acute injuries. And that the ankle is the most common acute tennis injury. And of course, most of these are inversion sprains. So we're going to concentrate on this, the inversion injury, which is so common in tennis. And to look at that, we need to look at the causes and also understand the stability of the ankle. So, like any joint, you've got the static and the dynamic stabilizers. And in the ankle, we've got the ankle mortise, which is a very good bony stabilizing factor. And we've got the ligamentous static stabilizers, and of course the peroneal musculotendinous unit as the dynamic stabilizer. This is the talus, and it's important to understand the shape of the talus if you're going to understand ankle inversion injuries. Who knows what a frustum is? This is for a gold star. It's a mathematical term, and it's a truncated cone. So if you imagine a cone with the top chopped off, that's the basic shape of the talus. So the narrow bit, the top bit, is on the medial side, and the wide bit's on the lateral side. Okay. If you imagine how a frustum moves, that gives you an idea that the foot will not move it's not a pure hinge. It will go one way and then the other. In fact, it's up and out and down and in. Okay, because of the frustum shape of the talus. We've also got this funny axis of motion in the ankle, which runs roughly between the tips of the malleoli, which also adds to it's partly a function of the frustum shape, but also means that when you dorsiflex, you'll go out, and when you plantarflex, you'll go in. Okay. The syndesmosis is always, I'm not going to talk much about the syndesmosis because it's not really a common injury in tennis. To injure your syndesmosis, you would normally have a dorsiflexion external rotation motion, so it's this kind of thing, okay, which is not as common in tennis. We're talking about this thing. But the syndesmosis, the fibula moves up by about 2 millimeters in ankle dorsiflexion, and externally rotates as well and opens up anteriorly. That's the external rotation. So even that part of the joint is not static. And then if we look at the ligamentous stabilizer in a bit more detail, we've got the ATFL, of course, which you'll all know, which is the most commonly injured because it's the weakest. So it's a broad, thin ligament, really just a condensation of the ankle capsule. Then you've got the CFL, the calcaneofibular ligament, which is less commonly injured, but very important clinically. So it's a little tube when you look at it when you're operating, as opposed to the broad, flat, sort of centimetre wide ATFL. The CFL is literally like a little tube. And the PTFL is so strong that it is very rarely injured and would more likely pull off an avulsion fracture than actually rupture itself. So that's the static stabilizers. Then we come on to the dynamic stabilizers. this thing about perineal reaction time, it may be oversimplistic. So there was a very recent meta-analysis which showed that if you look at patients who have had previous ankle inversion injuries, they have a delayed perineal reaction time. That would seem obvious to you, I guess. And that's obviously slower than the contralateral limb or healthy control. So looking at all of the papers that have been done on this, that seems to be the sort of consensus of opinion. But what about, there are lots of other things as well that are factors here. Strength, postural stability, and so on. And we're interested in, as surgeons, in this subtle cavus foot thing. So the posture or the version of the heel, whether it's in slight varus or not. Very, very important factor. And then there are these various studies on perineal neuromuscular control. They're all more or less the same kind of study. You'll get a subject walking along, a healthy volunteer, usually a medical student, and they'll walk along, and then all of a sudden the trap door in the floor will give way and they'll go over, and they'll be connected to sensory equipment, and then the studies will be looking at what happens to the motion in the ankle and what happens to the perineal muscles. Lots and lots of studies done like this. And what we know is that the perineal muscles react too slowly to actually stop the inversion injury happening. So by the time the event has happened, the perineal muscles haven't even started contracting. Okay, so what they actually do is they help avoid having the foot in the position at risk. So if your perineal muscles are walking normally, when you swing through, you're not likely to catch the front of your foot and invert your ankle. However, if you do, your perineal muscles are still not going to be able to react quickly enough to stop it from happening. Okay? So they're important, but not for the reason of stopping the injury from happening. They're important for preventing it from happening in the first place. What we do understand is better gleaned from looking at videos of real inversion injuries. And funnily enough, tennis is the richest source of this kind of data because we have lots of inversion injuries happening on camera. And what this very recent study showed was that it's the position of the foot at landing that's the most important determinant of whether there will be an inversion sprain. So if the foot, it sounds intuitively obvious, but if the foot is slightly internally rotated when the player starts to slide or land from their slight jump, then they are more likely to go over and invert their ankle than if it was planted straight. So actually, if all we have to do is go and tell our patients to put their foot straight when they're sliding to retrieve a drop shot, then you will have done them some good. So here's a few videos. Look at the right foot here, internally rotated, boom. Okay. Same thing in common, all of these. Look at the right foot on all these. I've got 3 of these. Because I'm just trying to wake you up, really. Right foot again, slightly inverted, okay? So these are just ligament injuries. These are not fractures. These are just lateral ligament sprains. And again, right foot in a horrible position and goes over. Okay, so it's the position of the foot as these players land or slide that puts them in trouble. So, first line treatment, it's a really common injury, as I said. It's as common as 1 ankle inversion per 10,000 people per day. So in England, that's about 5,000 a day are happening. And of course, most of them don't even get to see you, and even few of them get to see us, because most of them resolve very quickly. And the stat is probably that 95% of these resolve in about 6 weeks. Okay? It's very difficult to come up with an accurate stat, but this was a consensus from a statement from an organisation called ISOCOS, with a sort of organisation of leading sports surgeons from around the world. So that's the sort of worldwide consensus of what we can quote to patients. And the disability, this is a ridiculous figure. At a year, you can either be 10 or 76% likely to have a disability after an ankle inversion sprain, or anywhere in between. So that means nothing, and we don't really know. We don't really know. Is there evidence for acute repair? Well, it's controversial. One of the members of the Fortis group, James Calder, has published on this, and it's only really indicated in elite athletes, and surprisingly, there isn't a huge amount of difference in return to play between acute repair and conservative or functional treatment. So there's not an enormous difference. So what we do, there's a home exercise program. I mean, most of us would feel that Unsupervised program is not as good as a supervised program, and certainly with the current audience I would say that. And I think because of, if nothing else, because of compliance, because patients aren't as likely to comply with an unsupervised program. But it works, you know, there's a definite reduction in the risk of re-injury. So the evidence for a functional rehab of some sort is pretty much overwhelming. Taping, this is controversial. We all know that taping stretches out fairly quickly. I'm not sure if you recognise the high incidence of skin problems. I think they're all very minor skin problems. But there have been some studies that have shown that it prevents re-injury, probably in the very acute stages. I don't know how you'll all have your own opinions on that. Bracing, however, the evidence is pretty good. This was an interesting randomised controlled trial and showed that there were 3 groups. They either had neuromuscular or proprioceptive training for 8 weeks, or they had bracing for a year with no proprioceptive training, or they had both, but only with the bracing for 8 weeks. And the best group was the bracing for a year. And I would probably say that all that tells us is that proprioceptive training and a longer period of bracing is beneficial rather than just 8 weeks. And what about the other 5% who don't recover? So these are the ones that may end up coming our way. And you've got to think of associated injuries. Why are they in a 5%? Why haven't they recovered? So obviously there could be a fracture. But other common things we see are peroneal tendon injuries, chondral lesions, so articular cartilage damage, which may or may not involve some underlying bone as well. And then we sometimes see some longer term sequelae as well, and impingement will be the most common. Instability would be when the patient has recurrent inversion injuries, and occasionally you'll see a patient who's been going over on their ankle so many times over many years they'll actually present with osteoarthritis. This is a peroneal tendon subluxation, so here's the heel, the toes are down here. There's a great big pocket which has been lifted up on the outside of the fibula where this peroneal tendon just flops in and out of. Okay, and of course that can lead to splitting and fissuring of the tendon over time. On the right hand side there's an arthroscopic picture of an osteochondral lesion, a big flap of cartilage I'm lifting up with my probe there. So, ankle instability. I just want to emphasise these points because they're very important. Beware when you're taking a history from a patient and they say, my ankle gives way, because it doesn't always mean I am suffering recurrent inversion injuries. Often, the patient uses it to mean there's a sudden sharp pain, don't they? I don't know if you recognise that, but they'll take a step and all of a sudden they've got to take their weight off the ankle. Now that doesn't immediately to me say that their lateral ligaments are lax and they're rolling over. It means there's something going on in the ankle, but giving way to patients doesn't always mean what I understand as giving way. What's the difference between laxity and instability? So one is an examination finding, so the ligament is actually loose, and one is a symptom. The patient says my ankle's unstable. Okay? So it's important because only by understanding that can you understand the difference between functional and mechanical instability. So functional instability is when the patient is complaining of the ankle giving way, but the ligaments are not lax. Okay, we call that functional instability. So there can be a number of causes of that. The most common one is peroneal muscle, poor neuromuscular control. Mechanical instability is when the patient's ankle is giving way and the ligaments are lax. Okay, so that's where we're really interested because there's loose pieces of rope that we can potentially tighten up. And when you examine a patient, so here A is the CFL and B is the ATFL. When you perform your draw and your tilt test, just bear in mind that you need to be pulling forwards with the foot slightly plantarflex to test the ATFL. And you need to dorsiflex the foot and tilt the heel into varus to test the CFL. Okay, if you try and tilt the heel into varus when the foot is plantarflex, you'll be testing both really. Only by orientating that A ligament on the far right in a sort of fairly vertical position will you be purely testing CFL. Difficult to do. There's an anterior draw on the left and a varus tilt on the right. An anterior draw is the best, the better of the two. It's more sensitive and specific. So if the patient has failed neuromuscular rehab, then they may need an operation. And these are all fairly old-fashioned operations now. If you'd had an operation for ankle instability several years ago, you would have had a bit of peroneus brevis rerouted in some way or other through holes in the fibula. And the trouble with these operations is that they weren't particularly isometric. We have more isometric equivalents of those operations now, but they're big incisions, big exposures. Sometimes we may take a tendon from somewhere else like a hamstring and do this, but they tend to over-stiffen the joint. And we know from long-term studies that only about 50% are satisfactory, and there's even an incidence of osteoarthritis late on because of the over-stiffening of the joint. So this is the operation that we all love now. Have you all heard of this Brostrom operation? Yeah. So it's pretty much the operation we do now. It's the operation of choice. It's basically a delayed primary repair. We just go in and we find what's left, and there's always something left, or almost always. And you can either attach it to the fibula through drill holes, or more commonly via a little suture anchor widget with a little screw with sutures coming out of it. And you can hoik the ATFL and the CFL back on the bone and tighten it up. And we always, or almost always, combine this with an arthroscopy. And the reason is, here's a recent paper, there have been several like this. There is a high incidence of concurrent pathology when you perform an arthroscopy at the time of a Brostrom. And the most common thing is a bit of synovitis or impingement. And we can deal with that at the time via an arthroscopy. The other thing is, being just a primary repair, the Brostrom procedure is not as strong as the other repairs, which is an advantage in the sense it doesn't over-tighten the joint. But a disadvantage, I mentioned the varus heel scenario before. If you perform a Brostrom on a patient with a varus heel, so with someone who's slightly this way inclined, it won't be strong enough, it will fail. Okay, so we have to combine that with a heel shift osteotomy. We'll cut the heel, we'll shift it laterally at the same time as the Brostrom and realign their biomechanics. Rehab after a Brostrom is fairly quick. It's a day case operation. They have to look after their wounds, so they're non-weight bearing in a splint and elevating their foot at home for 10 days. Pretty standard for a foot operation. But after that, once the wound's healed, they can get weight bearing in something like an air sport brace. And I generally hold off physio until about 6 weeks, and then they can start a proper ankle rehab program, and you're looking for return to training 3 or 4 months. And the outcomes from this operation are really good, much better than the old operations. So we're looking at high levels of return to sport. More recent variations, arthroscopic Brostrom. There's several little techniques are being tried. I've tried this on dead German's ankles and didn't like it. Thermal capsular shrinkage, again, it's something that's been tried in the shoulder and various other joints in the body. There may be some promise. Personally, I think it's unlikely to be the answer. And then just to finish with, we come right round to bracing again, because a very recent modification is this idea of doing a Brostrom and then putting a little carbon fibre brace on top of your Brostrom reconstruction, thus the internal brace, which will prevent your Brostrom from stretching out in time. So it's slightly looser than the Brostrom, but it's just there as a little check rein. And the idea being that you can rehab athletes more quickly. I've used it, I've done about half a dozen, and for me it's more useful in patients with hypermobility syndrome and the occasional revision case where there's still some tissue left. But there may be some use for this in the future. I think that's quite a decent technique. That's it. Thank you.